Hey, community nursing concepts, exam one review. I do want to pause and just ask, do you have any specific questions about any one concept? Because I did want to just go ahead and address that. If not, I will just go ahead and go over the concepts for exam one. So I want to pause. Do you have any specific questions about any one concept? And I can
No, I
start.
do not.
Okay. All right. So I'm going to share my screen here and I am pulling up the blueprint and let's see here. Okay. So these are all the concepts that have been pulled from your required readings. And so we'll just go through these and you can stop me if there's a question, if a question arises as we review the information. So community oriented versus community based nursing. Remember, one, we're taking care of the individual, and the other, we're considering the entire community. Okay. So, community based nursing is a setting specific practice in which care is provided for the individual and maybe even the family, like where they live and where they work. So let's just give an example. Something that comes to mind, asthma comes to mind. We are teaching, uh, we are teaching about the new inhaler, the nebulizer treatment. We're teaching about how to use the blood pressure. They're supposed to keep a journal of blood pressure measurements. So we're going through the steps of how to apply the cuff, and then actually making sure that they write down the numbers appropriately, correctly. So we're working with those individuals, whether or not it is that one person or maybe two persons from that family. So that's community based nursing. So community oriented, we are focused more on the community as a whole. So with community based, with community oriented, focusing on the diagnosis, health surveillance, and evaluation of that broader population. So community oriented, an example would be we're setting up, they're having a health fair and we're setting up our booth and we have for asthma we may have filters out there for the individuals that have asthma for them to take home. Meanwhile, we're also providing literature in regards to how to use their spacer or just on some asthma basics. But in with that being said, community oriented, we're out there at the health fair, so we're not working specifically with the individual, but we're out there for the community as a whole. Okay, so primary, secondary, tertiary, and primary, secondary, and tertiary. We had those three levels of prevention. So, specifically for primary, we are wanting to inform, educate so that in hopes that an injury does not occur, in hopes that a disease process does not occur. So, we want to prevent it from ever happening. Okay. And so, some examples will be vaccinations, health promotion, lifestyle education. Even if we were coordinating a gun safety class, because we're educating in hopes that an injury does not occur. So we're preventing it from ever happening. So secondary is we are little detectives. We're trying to determine, we're trying to screen, we're trying to see if there is an injury, if there is a disease process. That's secondary. And so some examples of that would be like a TB skin test. We're screening, we inject the tuberculin, we make the little bleb, the person, the spot is marked, the person comes back and get that red. We may even give a two-step. But while we're giving that TB skin test, we're trying to determine if this person has been exposed to the tuberculin bacteria. So that procedure, that intradermal procedure, and then coming back and follow up and looking at that assessing an area however many days later, that is screening. That is screening. Okay. So let me go back to primary. An example of primary, we're preventing in hopes of preventing from whatever ever happens. So an example of that would be a vaccination. We're giving a vaccination for chickenpox. So we're hoping that person is taking that injection in hopes that they don't ever get chickenpox. So we're trying to prevent it from ever happening. And then tertiary, this is where an injury or disease process has taken place. And we are trying to assist that person to manage so that they can manage that chronic condition in hopes that they get back to that optimal level of care. Okay. So morbidity, mortality, we're looking specifically at the numbers, uh, the occurrence of asthma in a community, the occurrence of motor vehicle accidents in the area. And then in addition to that, how many people are actually passing away or dying as a result of that. So we always want to consider social economic factors when we are looking at and trying to come up with interventions for our clients, because social economic does play a huge part in if my environment. What does my environment look like? Is my environment so that uh, is it conducive for me to get out and walk? Do I have the funds? Am I able to be employed? Do I have food security? Do I have stable housing? So we do want to think about that financial piece. Okay. So vulnerable populations, we want to think about anything that's going to put that person at risk for them not receiving or being able to have that optimal level. Something that outright comes to mind is, our children, of course, because they rely on an adult. They rely on that parent or guardian to oversee and ensure that those things are there for them: food, water, and shelter. Now, if a person is an adult, but they have learning disabilities, that person is still vulnerable because the rate of their learning, they're able to understand if they have a disability is lessened. So this person is going to be vulnerable. So we will have to think of and generate and come up with different and additional resource for them, or just different types of resources, because it says that person has a learning disability. And like the child, they solely rely on a parent or guarding someone else, solely taking care of them, or at least having those things available so that they can live productive lives. So we have public insurance. That's going to be your Medicare and your Medicaid, and then your Veterans Administration, your VA insurance. Okay, so Medicare, we tend to think of, we want to take care of our elderly, and so there, so we think about 65 and older. Now there are some disease processes where you don't have to be 65 and you still qualify for Medicare. End-stage renal disease is one that comes to mind. So a person could be less than 65 and have Medicare because they have that end-stage renal disease. But traditionally, it is that person that is 65 and older. And so Medicaid is income-based. It is income-based. Okay. And then so if the person is younger than 65, but they have that end stage renal disease, they actually can qualify for both Medicare and Medicaid. So the Affordable Care Act was created or designed for how this first part right here, this word afford, so people could afford the health care. It allowed for individuals not to be penalized because they had a pre-existing condition. So prior to the Affordable Care Act, if a person, we just say, had hypertension documented on their record, insurance companies could decide whether or not they were going to pay for any services that were related to the hypertension because it was listed on your record. Therefore, it was a pre-existing condition. The Affordable Care Act, the purpose was to increase access to care by making options affordable and available. That was the whole purpose behind the Affordable Care Act. And with that, it had all the different tiers. It had the marketplace. You could go in and shop around, decide which insurance is best for you. Because if you have certain disease processes, you might need a different amount of MRIs or lab work done. So with the marketplace being there, you could go in there and pick out which plan was best for you. Affordable, making it available and affordable. So we do want to think about uh, the lifespan when we're trying to promote, because at our best and at our worst, we want to prevent um, any injuries or disease from happening. So that means that we want to reduce those risks, decrease those risks. And how do we do it? We strictly start off our foundation is primary intervention. We provide the education for health promotion. So just thinking about across the lifespan, we in a child, obesity, we want to ensure that we decrease the screen time. We want to make sure that fresh fruits and vegetables and things like that are available. We want to make sure that they have opportunities to run, jump, and hop so that they can exercise a variety of different things so that they can exercise. Remember, we are mandated reporters, so we have to report in it, even if there's a suspicion of child abuse and elderly abuse. We must report that. In reference to our teens, remember the bigger goal, a long-term goal would be that child completing their education. And short-term goals, we want to make sure that 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 child and the fetus are developing correctly. So we want to ensure that they have, access to fresh fruits and vegetables, healthy diet. Make sure that they get to their appointments before and after. So what you see though in school systems, they have a variety of they have some hybrid classes. They have, they don't have just where you have to come inside and sit in the seat. So, and that was created so that child could, complete their education, and so you will see those different. If you're that school nurse, you may be part of that plan and planning for that child, that expected mom, and also after that mom, gives birth. Going back to adolescent risk reduction, think about motor vehicle accidents, encouraging them to wear their seatbelts because the data does show that it reduces the risk of someone having an injury or passing away from if in the event they were involved in a motor vehicle accident. Gun safety classes. If the person decides they want a firearm, let's just make sure that they're aware of how to use it. When they're storing it, we want to store the actual firearm and then the ammunition separately. All right. And I think no, we haven't, okay, we haven't got down to Healthy People 2030 yet. So let's look at the evidence-based practice. Let's get the evidence-based practice. Okay. So that spirit of inquiry, that is where we're thinking about, well, hey, can we do this same process while using less time, less resources for our patient and for the person, the healthcare member that is actually implementing that? So cultivating a spirit of inquiry starts that with that clinical question. Okay. Asking that question and researching for it. What is the evidence show? We want to look at the evidence. Is it specific for this situation? Because when you're going to do a evidence search out there, you'll find information, just a huge amount of information. But we want to make sure that it's specific to what we are getting ready to implement. You want to consider the setting. Is this the urgent care setting or is this acute care? So then we want to put the evidence, integrate the evidence. Then we want to evaluate it. the outcome. And then we want to disseminate the outcome. Usually the gold standard is randomized control trials when we are utilizing this evidence-based um, practice. So think about also quantitative and qualitative. Quantity, these are measurements. So that data, that research is in the form of some type of measurement, whether or not it's blood pressure measurements, whether or not it's that red blood cell count measurement. It could be echocardiograms, whatever those findings are, but it's some type of measurement, the height and weight. So qualitative is information or evidence that is gathered from an interview. And that interview can take place in person, via Zoom, via a questionnaire that the person completes and they turn it back in. So, but nevertheless, it's still information that's gathered, but it doesn't have quality to it, like the blood pressure numbers and the height and the weight. That's qualitative. All right. So, and then if I'm like I say, if any questions arise, please stop me and we can talk about, if a question has arise. So we're going to Healthy People 2030. So every 10 years they revise and update the Healthy People goals. And so and it does address everything from A to Z, this Healthy People 2030. It's in hopes of that individuals will attain healthy lives. That it promotes healthy behaviors, and so it promotes healthy development. It achieves health equity. It eliminates health disparities. It considers everything. Like the example that I gave about the social economic Healthy People 2030. If you get a chance, look at it. Make sure you look at those examples in your book. It does have like those charts that have examples, excerpts that are pulled out of the Healthy People 2030. So for example, it will look at what was the example I gave? The social economic. So it will give, it'll discuss, what it means, like the financial piece. And then it will guide the person to think about, the education level that's required so that a person can gain that skill set. And we're talking about hard skills and soft skills so they can acquire that job and also maintain that job so they can provide for themselves and their family. The Healthy People 2030 goals, the big picture is so that people can have and live healthier lives, promote healthy behaviors. And then it considers the public, because for the most part, if you're living in a neighborhood, that neighborhood belongs to some, a principality. It could be a uh, small community, it could be a ward, it could be a parish, but nevertheless, it's governed by some type of public entity. And we want their buy-in as well, because if we need sidewalks repaired, if we need more jobs to come to our area, that public entity, that mayor, those commissioners, and they call them different things, depending on your state, but those are the ones that will need to buy in to so that in hopes of asking people in industries and things like that to come to those communities so that people can actually have the opportunity to get jobs, good paying jobs. All right. I think that was all I was going to say about Healthy People 2030. But ensure that you're going back and looking at those charts that are in the required reading chapters. Like I say, it considers, the access. Is there emergency room in the area? If there's an urgent care, and then it points out things, interventions, and gives some suggestions, you know, for specifically for the task. Even gun violence, and like I said, 2030 Health People 2030 addresses so many different areas. It's considering the whole person. So we have family development. So we have dysfunctional families and functional families. And what that means is a dysfunctional family, it doesn't mean that the family is bad. Is this when a family is dysfunctional, they're not equipped to be able to respond in the event that a crisis happens. And crisis varies. It could be from the sole breadwinner um, not being able to work and provide for that family. What does that family do? Do they have the tools to or the resources to be able to pivot so that that family can continue to be provided for? So in the event that they don't, then that family becomes dysfunctional and is not able to perform and take care of the individuals that are inside that family. So understanding roles and the dynamics, sometimes we have to schedule those home visits, and making sure that, at a minimum, those key players, the key family members are there. We want to, if when we go into the home, we want to think about, we're going to plan for the visit. You want to make sure that, that you're available when the family is available, because in the event that we're going to do that home interview and the family members are key role, at least at a minimum, those key family members are not there, then we're not going to get as much information as we need to create that care plan and come up with those resources and identify those resources so that that family can be functional. So we want to keep that in mind. We might need an interpreter there. Like I said, we do want to plan. You might need an assistant, and you always want to be aware of your safety when you're going into um, the client's home. Let me go back to community. So something just came up in my mind, the windshield survey. That is where we go into the community and we essentially are observing, what are we seeing? What are the interaction? What resources are there? Do they have sidewalks? Is there a place for children to go and play? Are there grocery stores there? So this windshield survey allows us to be up close and make observations in the community. And so that when we create this community care plan, we are addressing real things, real issues that is located in that community. So as that school nurse, we wear many hats as a school nurse. Nevertheless, we're going to provide that care for that client. We want the client or the patient or the children, the students that are there. And so many times we administer medications. There are some times we have to provide that emergency care for the client, the patient, the students. For example, if they're out on the field, they're playing flag football and someone falls and injures themselves. We have to provide that emergency care as well. We might be overseeing unlicensed personnel on the school grounds, because they do have programs where the unlicensed personnel, most time is the school teachers. They can be trained to administer certain medications, but you'll wear many, many hats. And so remember, we are mandated reporters if there is suspected or known child abuse or neglect. And just think about what that looks like. Those injuries, the unexplained injuries, they may have bruising. The child may look unkept. They may have on, they may have dirty clothes on. They may act as though they haven't eaten or don't have access to food. So we are mandated reporters though. And also as a school nurse, we function to ensure that that child continues to learn. That's the whole purpose of coming to school, so that they can learn, they can be interactive with their peers. So we're there so that they can continue that process. They are pulled away from the classroom for just a very short amount of time. But the whole idea is to have that well child there and them interacting and gathering the tools that they need. Now, we as a school nurse, we may assist also with scoliosis screening. We may assist with light screening. We may also assist with hearing and vision screening. We might even be called upon to present at the PTA. So, like I said, as a school nurse, you're wearing many hats, but the overarching goal is to provide that care to that child so that they can still, function and get their education. Get their education. As always, remember you do have math on your on the exam, so make sure you have your dry erase board. You can also have a sheet protector. Make sure you have your identifications. Let me go back to the family. Something just came to mind. The genogram. Remember, we use the genetics. That's a map where we look at the genetics. We look at that family, the family history. On the mom's side, who are the mom and dad, and then on the mom's side, what disease processes were there? And then what age did these things occur? Um, that was something I forgot to say about the family. And in addition to looking at that genogram, looking at the family genetics, we could also do that eco map where we're looking and thinking and considering about the environment, visualizing the family's relationship with outside systems. And those outside systems are schools, the places of faith. And the whole purpose is to identify if there are any social risk factors. And then also, are there any social networks or support that's already there inside of that community? Because a lot of times there are resources, and the people just don't know that they even exist in their communities. So going back to that home visit, we want to in assessments are voluntary. Families make judgment calls on the first call. We want to identify ourselves. Go back to that part. This family right here. Identify ourselves, and we want to tell them our purpose. Like I said, we do want to arrange and make sure that we're there at a convenient time for the family. All members may not be available, but that's okay as long as we have those key members that are there. We want to make sure that we know where we're going because we don't want to be at the wrong address, the wrong home, and then determine if you need an escort because we want all else. We want you to be the nurse to be safe. And then we want to assess and look and talk about those factors that puts them at an increased risk for not being functional in the event that a crisis happens. Looking at the likelihood of an illness occurring in that family. And that's when you can go back and look at the genogram. What illnesses are known for this family? Are there any primary prevention? Are there any, so that we can prevent it from ever happening? Are there any secondary? Are there any screenings that this family needs? For example, lead paint. Do we need to bring do the family need to go in and get lead tested? We want to also, I did say about reducing the risk. And so that in the event, we don't want someone to be injured in their home because the family has firearms in it. So we want to consider have they had this gun safety class? Do they understand how to use their firearm? Now, at a minimum, go back through your classroom recordings. We are uploading the exam reviews as they happen. So go back to that tab that's in your announcement section. We're adding them as they happen. So go there. There are about, I think it's 6 or 7 of us. So there should be at least 6 or 7 different reviews. So make sure that you're going back through those. And also, you still have time to reach out if there's a concept that you're unfamiliar with or you still have questions about. And so I always reach out to your professor in the event that there are questions, and you can send emails. We can jump on the phone. We can actually, Zoom if needed. But make sure you go back through your classroom recordings, week 1 and week 2. Make sure that you can use your blueprint as we have it here on the screen, and just do some jot noting. Write down, what do you know about each of these topics and what questions you have, and that helps you to sift through what you have an understanding of and those things that you need more information about. Make sure you have your IDs. Ensure that you have completed that practice exam. That ensures that your computer has met all the specifications. And so that on exam day, you don't run into any problems downloading that exam. In the event that you have accommodations, please submit the approved accommodation letter to your professor so that those accommodations can be provided. And then remember the proctoring 72-hour notice. Your campus dean has to approve it. Your campus dean has to approve the faculty that will proctor it. And also the course leader for this course is Dr. Lundy, and also whomever your course professor is. All of them need to be in communication about what's happening, when, so that you can take your exam and do your best. I'm going to pause here. Are there any questions about any one concept? If not, I'll go ahead and end this recording. As soon as it downloads and uploads, we'll send it out. But be checking that tab because we're adding them in there as the exam reviews are occurring. Happy learning. I'm not hearing any questions, so I'll go ahead and end.